Let's look at some review questions for the pulmonary system. So, question 1. A 45-year-old accountant presents to the ED complaining of hemoptysis, shortness of breath, and right-sided chest pain, which is worse with breathing. His past medical history includes hypertension and obesity, with a BMI of 33.2. He's presently hemodynamically stable. Blood pressure is elevated at 175/98, heart rate 120, respirations 18, temperature of 98.1. On physical exam, there's +3 out of 4 pitting edema and erythema of the left calf. Supplemental oxygen's been initiated. Chest x-rays unremarkable. Which of the following is the next best step? A. Pulmonary angiogram. B. Helical CT of the chest. C. EKG. D. Duplex ultrasound of the left leg. Or E. Watchful waiting. And note that this is the next best diagnostic step. So we're looking for what the next best step is to diagnose what this patient has, not necessarily the next best step in treatment. Right, and the answer here is B. So we are going to go ahead with a helical CT because in this patient we already have a presumptive diagnosis of pulmonary embolism. Why are we not doing the duplex ultrasound? Because this patient has respiratory symptoms. Because the patient has respiratory symptoms, we're more concerned about the pulmonary embolism rather than the DVT. We are practically certain that this patient has a DVT because not only do they have the symptoms of a DVT, but they also have symptoms of a pulmonary embolism. So we're not going to waste time trying to see, does this patient have a DVT? We know that they've got the symptoms of a DVT. We're more concerned about the pulmonary embolism because that can actually kill the patient. So, we can, after we diagnose the pulmonary embolism, we can look and see where the DVT is and put that on the record. But what we're most concerned about here is the pulmonary embolism because that can kill the patient. So the Wells criteria for pulmonary embolism, remember that I would remember this scoring system, but the threshold is not very high. So if the patient has DVT symptoms, that's already 3 points. If the patient has more than 4 points, then you're already working on the presumptive diagnosis of a pulmonary embolism. So the DVT symptoms are already 3 points, so you're already 3/4 of the way there. If pulmonary embolism is number 1 on your differential, which it can easily be, then there's another 3 points. I would put pulmonary embolism number 1 on the differential here because this patient has pleuritic chest pain. And pleuritic chest pain is very typical of pulmonary embolism. There's a lot of P's that give you pleuritic chest pain. Pleurisy, pneumothorax, pulmonary embolism, even pneumonia can do it. So a lot of the things that start with P give you pleuritic chest pain. So there you have 6 points right there. You have a heart rate of over 100, that's another 1.5 points. This patient was not immobilized and did not have surgery in the last 4 weeks. And he does have hemoptysis, as you can see here. So this patient has 8.5 points. He more than qualifies for likely pulmonary embolism. So what do we do? If the patient falls under the likely category, we go ahead with the helical CT. Of course, we're giving this patient supplemental oxygen already, but that, I believe it did say that in the question. Okay, it didn't say that in the question, but the answer, or the question was, what's the next best diagnostic step? So it is helical CT. But supplemental oxygen would be started as the next best step in therapy. So helical CT is your next step for diagnosis, which will probably come back positive, and then you begin therapy. Therapy is going to be with IV heparin. You're going to admit this patient to the ICU and then start warfarin on day 3, and you're going to monitor the patient with repeat arterial blood gases and INRs. You're going to want to get this patient up to an INR around 3. And if the patient were to be under the unlikely category, then you get a D-dimer. The D-dimer was high, then you go ahead with the helical CT. If the D-dimer was normal, you could rule out pulmonary embolism. A normal D-dimer pretty much always rules out pulmonary embolism. So a that's why it's good to get a D-dimer in a patient where pulmonary embolism is questionable. If pulmonary embolism is very likely, though, you're not even going to bother with the D-dimer. Okay, question 2. 30-year-old female is hospitalized following a motor vehicle accident. She suffered 5 fractured ribs as well as multiple contusions over her chest and upper right arm. As you look at the chest x-ray, you note a 0.8 centimeter calcified nodule with smooth margins in the right middle lung field. No previous chest x-rays are available for comparison. Physical and routine labs are unremarkable. She has smoked 1 pack per day for the last 10 years. Which of the following is the most likely diagnosis? A. Bronchogenic carcinoma. B. Aspergilloma. C. Pulmonary hamartoma. D. Tuberculosis. Or E. Sarcoidosis. Right. Well, the answer here is C. Pulmonary hamartoma. So this is a patient with a nodule, a pulmonary nodule, and it's solitary as far as we know from this chest x-ray. So it's just 0.8 centimeters, and it's in the right middle lung field. So you have a solitary pulmonary nodule. What do you do with that? Well, if it's clearly malignant, that would be in the case if it was an older patient, very long smoking history, non-calcified, non-homogeneous, irregular borders, then you would go ahead with a CT. If it's clearly benign, which I would say it is in this patient, first off, this is a young patient. She hasn't been smoking very long. She is a smoker, but she hasn't been smoking long, only 10 years and one pack per day. So that's not a long time to be smoking. You would not expect a 30-year-old woman to be getting lung cancer. She's also got the nodule is only 0.8 centimeters, so that's quite small. It's calcified, which also points to benign, and it's got smooth margins, which also points to benign. So all of that put together, her short smoking history, her young age, and the appearance of this nodule all points to a benign nodule. So the question then is, what is this? Well, we've already ruled out bronchogenic carcinoma, which is just another word for lung cancer. Aspergilloma is a possibility, but it's less likely because aspergilloma is rare. Tuberculosis is also less likely because in the US, tuberculosis is also very rare. Sarcoidosis is less likely because we don't see hilar lymphadenopathy on the chest x-ray. It doesn't note that. Furthermore, with sarcoidosis, she would have other symptoms, including lupus pernio. She could have abnormalities of the bones besides her fractured ribs. She could also have abnormalities of the eyes as well. So pulmonary hamartoma is the most likely, and if you were to get a CT to look at the hamartoma, you would see the popcorn appearance, popcorn ball appearance. Okay, so when you're working up a solitary pulmonary nodule, if the nodule is clearly malignant, if the patient's older and the nodule is non-calcified and heterogeneous and irregular borders, you're going to go ahead and do your biopsy. More than likely, in real life, you're going to get a CT because you need to know exactly where you're going to be going when you do your biopsy. If you're doing a bronchoscopy or a fine needle aspiration, you need to know exactly where you're going to be going. So usually you're going to need a CT. Your surgeon or whoever is doing the biopsy is going to want to have that CT anyway. So the way you're going to do the biopsy is going to be either through flexible bronchoscopy or fine needle aspiration. The way we determine this is if it's a central lesion, then we're going to do a bronchoscopy. If it's a peripheral lesion, we're going to do a fine needle aspiration, and we'll be able to tell that on CT and on chest x-ray. If it's questionable, if it's not either clearly benign or clearly malignant, then the next best step is to get a CT, and the CT will give us a better definition of whether this is possibly a malignant tumor or if it's possibly a benign tumor. And most of the time, we are going to get the CT first because it's very difficult to define a nodule as clearly benign. We don't want to take that risk. Now, in this patient, she's young, she hasn't been smoking very long, and this nodule has got all of the characteristics of a benign lesion. So in this case, we are going to just follow up. We don't even need a CT. But in real life, most of the time we get that CT just to make extra sure, because we don't want to send a patient home, that 1 in a million that it looks like a cancerous nodule, or it looks like a benign nodule, and it turns out to be cancer. Then you may get sued for malpractice. So usually we get the CT anyway, but on the USMLE, don't practice defensive medicine. So I'm just kind of delineating what happens on the USMLE and what happens in real life. If it's clearly benign on the USMLE, you're just going to follow up. If it's questionable or clearly malignant, get the CT. And then once you get the biopsy, if it's malignant, you're going to assess for therapy, and that's going to include getting various tests like skeletal, radionuclide imaging, PET scan, whole body CT, labs, etc. If it's benign, then you're done with your diagnosis. Okay, question 3. A 60-year-old man is presently hospitalized for an episode of acute pancreatitis. His hospital course is stable. He's managed on fluids, antibiotics, and enoxaparin. On day 2 of admission, he develops shortness of breath and severe anxiety. Blood pressure is 130/90, heart rate's 120, respirations are 23, temperature is 97.4. Patient or physical exam is notable for accessory respiratory muscle use, bilateral rails. Chest x-ray is remarkable for bilateral patchy infiltrates. Labs are remarkable for leukocytosis, bicarb of 28, blood pH of 7.31, a oxygen of 60, arterial carbon dioxide of 55 millimeters of mercury. Renal function is normal. Which of the following is most likely diagnosis in this patient? Is it A, septicemia, B, cardiogenic pulmonary edema, C, pulmonary embolism, D, Goodpasture syndrome, or E, acute respiratory distress syndrome? All right. And the answer here is E, acute respiratory distress syndrome. So this is a patient that has developed respiratory distress after an acute event. So any kind of acute event, so trauma, pancreatitis, another thing could be sepsis. Of course, this patient didn't have sepsis, but another thing could be any kind of infection, any kind of acute event that would land a patient in the hospital. Any of those things can lead to ARDS. So you have to be thinking that anytime you have a patient in the hospital, because most of the time when patients are in the hospital on the general wards, something landed them there. And usually that thing can cause ARDS. A wide range of things can cause ARDS. Now you have this patient on fluids, you have them on antibiotics, and you have them on enoxaparin. A way that you can rule out septicemia is 1, this patient has normal renal function. Usually in septicemia, the renal function will be disturbed. And 2, this patient is already on antibiotics. So those 2 things make it very difficult to develop septicemia. You can outrule cardiogenic pulmonary edema because this patient does not have an enlarged cardiac silhouette on chest x-ray. Cardiogenic pulmonary edema and ARDS both look the same as far as clinically, but on chest x-ray you'll be able to differentiate the 2, because with cardiogenic pulmonary edema you have difficulty pumping on the left side of the heart, and so fluid gets backed up. But in order to have cardiogenic pulmonary edema, you've got to have an enlarged cardiac silhouette. Pulmonary embolism is also unlikely in this patient because he's on enoxaparin, and if you're already on unfractionated heparin or low molecular weight heparin, it's going to make it very difficult to develop an embolism. Furthermore, we don't see any signs of DVT in this patient. Goodpasture syndrome is very unlikely in this patient. Goodpasture syndrome is an autoimmune disease. It affects the kidneys and the lungs, and this patient has appropriate renal function. Also, this is an acute event. Goodpasture syndrome tends to be more chronic. Okay, question 4. So we've got the same patient. We already have diagnosed him with ARDS. Which of the following is the next best step in this patient? A, supplemental oxygen ventilatory support and ICU transfer. B, supplemental oxygen ventilatory support and IV hydrochlorothiazide. C, the oxygen plus generous fluids. D, the oxygen plus digoxin. Or E, tracheostomy. All right, and the answer here is A, supplemental oxygen, ventilatory support, and ICU transfer. So more than likely, we would have already given the patient supplemental oxygen while he was in respiratory distress. But I did want to delineate here that this is part of therapy. So supplemental oxygen and ventilatory support are always your first step in the management of a patient with respiratory distress. That goes without saying, but it's very important to remember that. So we always manage our ABCs first. However, when we're looking towards diagnosing ARDS, we have to do chest x-rays, labs, arterial blood gases, and so forth. But for therapy, we always give supplemental oxygen and ventilatory support. Apart from that, then, it's just going to be supportive therapy. There's nothing we can really do for ARDS besides making sure that the patient has enough oxygen and that we want to make sure that their saturation is above 88 to 90%. So usually this is going to mean monitoring in the ICU, and supplemental oxygen and ventilatory support are central to therapy. Hydrochlorothiazide is not useful in ARDS. This is not a cardiac disorder. This is strictly due to the lungs and the lung parenchyma. Generous IV fluids are absolutely not indicated in ARDS. While we do give the patient fluids, we want to be as conservative as we possibly can be. And digoxin is also not indicated here because this is not a cardiac disorder. Tracheostomy would be something that we might look towards if the patient has been on prolonged intubation. Then tracheostomy may be something that we would do. But this patient has only been in the hospital for 2 days. He's only developed ARDS recently, so we're going to give him supplemental oxygen ventilatory support, and that may mean nasal cannula, that may mean a mask, that may mean intubation, but we don't go to tracheostomy first. That's something that we do after the patient's been intubated for a long period of time. If they're going to need continued ventilatory support, then we use tracheostomy. Question 5. A 62-year-old male presents for routine annual physical examination. He has no complaints at this time and enjoys an active retired life playing tennis with his wife weekly and says he can keep up with his grandchildren. He has never smoked. Physical and routine labs are unremarkable. His records indicate that he worked in pipe fitting for 25 years and some of his colleagues developed mesothelioma. Which of the following chest cancers is this patient at greatest risk for? A, small cell lung cancer. B, adenocarcinoma of the lung. C, large cell lung cancer. D, squamous cell lung cancer. Or E, mesothelioma. All right, and the answer here is B, adenocarcinoma of the lung. So it's very important to remember, with exposure to mesothelioma, it increases your risk by 75 times. It increases your risk of bronchogenic carcinoma, so any of the lung cancers. It also increases your risk significantly of mesothelioma. However, when you are exposed to asbestos, you are still more likely to get lung cancer from that exposure than you are to get mesothelioma. Mesothelioma is particular to patients with asbestos exposure, but it is not the most common cancer in patients with asbestos exposure. Now, adenocarcinoma of the lung is the most common lung cancer, and it is also the most common lung cancer in patients who are non-smokers. And this is a man who is a non-smoker. So adenocarcinoma of the lung is most likely here. But this is a guy that has by no means any kind of lung symptoms, so we're not concerned about lung cancer particularly right now, but it does need to be noted that he was exposed to asbestos, so that if he starts to develop any kind of symptoms whatsoever, that we get him checked out right away. Unfortunately, though, we don't have any screening for lung cancer, so usually when the patient develops symptoms of lung cancer, it's usually too late. Okay, question 6. A 28-year-old male presents to the clinic complaining of shortness of breath. He says that this has been a persistent problem for him over the past several years, but has gotten worse since he started smoking 2 months ago. Physical exam is notable for obesity. He's got a BMI of 35.1 and wheezing. Chest x-ray and routine labs are unremarkable. Pulmonary function tests reveal a decreased FEV1 to FVC ratio, which does not improve with the administration of a beta agonist. Which of the following is the most likely diagnosis in this patient? A. Asthma, B. COPD, C. alpha-1 antitrypsin deficiency, D. Idiopathic pulmonary fibrosis, or E. Obesity hypoventilation syndrome. And the answer here is C. alpha-1 antitrypsin deficiency. So this is a young guy. He's 28 years old. He's only been smoking for 2 months. That's certainly not long enough to get any kind of complication from smoking. So we are concerned because he does have this chronic shortness of breath, and he also has wheezing, and he's got pulmonary function tests, most importantly, that are abnormal. An FEV1 to FVC ratio that's lower than normal, and he's got, it doesn't reverse with the administration of a beta agonist. So that points to either COPD or an alpha-1 antitrypsin deficiency. Remember that asthma, yes, you will have an FEV1 to FVC ratio that's decreased, but it will reverse with the administration of a beta agonist. In this case, it didn't. So we know that he's got either COPD or alpha-1 antitrypsin deficiency. Idiopathic pulmonary fibrosis is a restrictive disorder, and so we would expect to see a normal or increased FEV1 to FVC ratio, and we would see decreased lung volumes overall. Obesity hypoventilation syndrome is not likely in this patient. 1, because it's rare. 2, because he is obese, but he's not that obese. Obesity hypoventilation syndrome is something that you would see in the morbidly obese patient. 2, there is reason to believe that he has alpha-1 antitrypsin deficiency for 2 reasons. 1, this has been a persistent problem for the past several years, and 2, it got worse when he started smoking. That points towards an alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency can be subclinical in patients until they start smoking. And then once they start smoking, it gets significantly worse. So that is something that you tend to see with alpha-1 antitrypsin. And then, of course, as I mentioned, we rule out COPD just simply because he is a young guy and he hasn't been smoking very long. IPF and obesity hypoventilation, they're both restrictive disorders. So remember for the test and for real life how to distinguish your obstructive versus your restrictive disorders. All the obstructive disorders have a decreased FEV1 to FVC ratio. Your restrictive disorders will have a normal or increased FEV1 to FVC ratio and decreased lung volumes. So just from there, we've ruled it down to A, B, and C. With the FEV1 to FVC ratio, which is decreased in patients with obstructive disorders, if it is reversible with the administration of a beta agonist, it's more than likely asthma. If it's not reversible, it's more than likely COPD, possibly bronchiectasis, or alpha-1 antitrypsin deficiency. A 58-year-old woman presents to the clinic complaining of shortness of breath and productive cough, which has been progressively worsening over the past several months. She has smoked 2 packs per day for the last 40 years. Physical exam is remarkable for wheezing and rails bilaterally. A trial of albuterol does not significantly improve her wheezing or her pulmonary function tests, which consistently show an FEV1 to FVC ratio of 45 to 50%. Which of the following is the best therapy in the management of this patient? A, prednisone, B, salmeterol fluticasone, C, albuterol, D, theophylline, or E, montelukast. So try and figure out what this patient has. How do we treat it? And the answer here is B, salmeterol and fluticasone. And that'll be in the form of an inhaler, of course. So this is a patient who has COPD. Unlike the previous patient, this patient has an extensive smoking history. So we're concerned with the more common obstructive disorder that's not reversible with administration of albuterol, and that would be COPD. So as far as we're concerned with the obstructive diseases that aren't reversible with a beta agonist, just think in the younger patients, it's going to be alpha-1 antitrypsin. In the older patients, it's going to be COPD. So this is COPD, much more common. What do we do for this patient? Well, we give all COPD patients a long-acting beta agonist, and we also give them home oxygen. That's just the very, very, very basic part of their therapy. We're not going to give a steroid. Albuterol is a short-acting beta agonist. That's something that we're going to give for asthma. And then theophylline and montelukast. They play roles in asthma as adjunctive therapy, but not for COPD. So salmeterol and fluticasone. Question 8. A 71-year-old male presents to the ED complaining of blood-streaked sputum and dyspnea on exertion. His past medical history is significant for COPD. He has smoked 1 pack per day for the past 55 years. Chest x-ray reveals a 1.4 centimeter non-calcified nodule centrally located by the bifurcation of the trachea. No previous imaging is available. CT has corroborated the chest x-ray findings. Which of the following is the best next step in management of this patient? A, flexible bronchoscopy, B, fine needle aspiration, C, video-assisted thoracoscopic surgery, D, whole body PET, or E, skeletal radionuclide imaging. All right. And the answer here is A, flexible bronchoscopy. So unlike the question that we had a few questions ago, this is a patient where we are really concerned about lung cancer. There are several reasons. 1, his age. 2, his extensive smoking history. 3, the nodule is larger. D, it's a non-calcified nodule. So those are all reasons to think that he may have lung cancer, and also the blood-streaked sputum. So, at the very minimum, this is suspicious for malignancy. So we are going to do a biopsy. We've already gotten a CT, which has corroborated the chest X-ray findings, and the CT, like I said, the surgeon is going to want the CT anyway. So now the next step is going to be to get the biopsy, because we want to know, is this a malignancy, which it almost certainly is, and if it is a malignancy, what kind of malignancy is it? Because that's going to play an impact on how we're going to treat him. Now, whether we do flexible bronchoscopy or fine needle aspiration, which either are used for getting biopsy, that's going to depend on what kind of tumor he's got, what kind of lesion. If it is a centrally located lesion, meaning closer to the larger airways, then we can use flexible bronchoscopy. If it's a peripheral lesion, meaning closer to the parenchyma, then we're going to use a fine needle aspiration. Video-assisted thoracoscopic surgery can be used for peripheral lesions if fine needle aspiration fails. And whole body PET and skeletal radionuclide imaging are used once we've diagnosed the patient with cancer to see if there are any metastases. Okay, so we have the same patient here, and the biopsy is returned and shows small cell carcinoma of the lungs, which I will just point out. In centrally located lesions, it tends to be either small cell carcinoma of the lungs or squamous cell carcinoma. And then in the peripheral lesions, it's either large cell carcinoma or adenocarcinoma. Okay, so continuing with the same patient, biopsy has returned and shows small cell carcinoma of the lungs. Which of the following chemotherapeutic regimens is appropriate for this patient? Is it A, cyclophosphamide, adriamycin, and carboplatin? B, cyclophosphamide, vincristine, adriamycin, and dexamethasone? C, cyclophosphamide, daunorubicin, vincristine, and prednisone? D, cytarabine and daunorubicin? Or E, carboplatin and etoposide? Okay, I'll give you some time to pause it. And the answer here is E, carboplatin and etoposide. So this is a patient with small cell lung cancer, and the oncologist, when you're thinking about how you treat a patient with lung cancer chemotherapeutically, you divide it up in between small cell lung cancer and the rest, the non-small cell lung cancers, which is squamous, large cell, and adenocarcinoma. So if the patient has small cell lung cancer, then you treat the patient with a platinum agent and etoposide. So that's the answer here. If the patient has non-small cell lung cancer, so if it's adenocarcinoma, large cell, or squamous cell, then you're going to use the CAP therapy, CAP, and that's going to be cyclophosphamide, adriamycin, and carboplatin. Just think of the P as a platinum agent, so carboplatin or cisplatin, it doesn't matter. We tend to use carboplatin because it's got less ototoxicity and less renal disease from it. Okay, cyclophosphamide, vincristine, adriamycin, and dexamethasone is the CVAD therapy, CVAD. That's used for, if you remember from hem-oncology, it's used for ALL, acute lymphocytic leukemia. Cyclophosphamide, daunorubicin, vincristine, and prednisone, what is that? That is CHOP, C-H-O-P, and that is used for non-Hodgkin's lymphoma. And then cytarabine and daunorubicin is used for AML. So we can see here, A is used for non-small cell lung cancer, E is used for small cell lung cancer, and these ones in the middle here are used for ALL, non-Hodgkin's lymphoma, and AML. Okay, so we have the same patient here, and this question is asking which of the following presentations would not be expected in a patient with small cell carcinoma of the lungs. Is it A, shortness of breath and hemoptysis, B, symmetrical weakness of the proximal muscles improved with activity, C, AMS and hyponatremia, D, AMS and hypercalcemia, or E, asymptomatic? All right, and the answer here is D, AMS and hypercalcemia. So there are various ways that a patient can present with lung cancer, with small cell carcinoma of the lungs. So this patient presented with dyspnea on exertion, which you can say is shortness of breath, and blood-streaked sputum, which is hemoptysis. So that right there eliminates A. He has small cell lung cancer, and indeed many patients with any lung cancer present with shortness of breath, and hemoptysis. Now, the other ones are related to paraneoplastic syndromes. Well, except for E, asymptomatic. Of course, you can have lung cancer and be asymptomatic. That's like the patients where we discover it incidentally. So, you know, A and E are out then. But the other three, B, C, and D, are all paraneoplastic syndromes. You should be aware of what the paraneoplastic syndromes are for the lung cancers, because the USMLE likes to throw these at you. I'm not going to say that it comes up that commonly in real life, but it's useful to know, and the USMLE likes to ask questions about it. So, symmetrical weakness of the proximal muscles improved with activity. So by proximal muscles, I mean muscles of your thigh, muscles of your upper arm. Symmetrical weakness of proximal muscles that's improved with activity is Lambert-Eaton myasthenic syndrome. So this is a paraneoplastic syndrome that is associated with small cell lung cancer, and this just has to do with the acetylcholine production and reception at the muscle. So you should know that this is associated with small cell lung cancer. So Lambert-Eaton myasthenic syndrome, and it shares some similarities as far as weakness with myasthenia gravis, but the difference from myasthenia gravis is that with myasthenia gravis, the weakness is worsened with activity. With Lambert-Eaton myasthenic syndrome, it tends to be improved a little bit with activity. AMS and hyponatremia would be a sign of SIADH. So hyponatremia causes the AMS, and the SIADH is an increased production of antidiuretic hormone, which increases the fluid on your blood, and that's going to decrease your concentration of sodium. And hyponatremia causes the AMS. So SIADH is another paraneoplastic syndrome of small cell lung cancer. Those are the two big ones for small cell lung cancer. Lambert-Eaton myasthenic syndrome and SIADH. So what is this AMS and hypercalcemia? This is not related to small cell lung cancer. This is related to squamous cell lung cancer. In squamous cell lung cancer, the tumor can produce parathyroid hormone resembling peptide, so PTH-RP. And parathyroid hormone resembling peptide is just a protein that acts like parathyroid hormone. It is not parathyroid hormone, but it acts just like parathyroid hormone. So it increases the absorption of calcium, and it increases the metabolism of bone. And so those two things are going to cause hypercalcemia. You're also going to have a decreased concentration in the blood of parathyroid hormone. Why? Because if you have high calcium, that's going to feed back to the parathyroids and tell it to shut off parathyroid hormone production. When you get your labs, you're not going to see parathyroid hormone because, remember, this protein is not parathyroid hormone. It's just parathyroid hormone resembling protein. So you're going to have a high calcium level. If your calcium level is high enough, you can have altered mental status. And indeed, most patients who have a really, really high calcium, if they present, and it's not just a coincidental finding, usually they'll have some level of altered mental status. Okay, 28-year-old female under your care with a past medical history of polycystic ovarian syndrome and panic disorder presents to the ED complaining of chest pain and shortness of breath. Her initial vitals were blood pressure of 160 over 100, heart rate of 120, respirations 22, and temperature of 98.9. Chest x-rays unremarkable. On presentation, she has right-sided rales, tachycardia, and left calf erythema and edema. Her present medications include heparin, citalopram, alprazolam, albuterol, medroxyprogesterone, and acetaminophen. Which of the following medications should be discontinued? A. Citalopram, B. Alprazolam, C. Albuterol, D. Medroxyprogesterone, or E. Acetaminophen. And the answer here is D. Medroxyprogesterone. So in this woman, you have what appears to be and is most certainly a pulmonary embolism. So we can tell that it's pulmonary embolism, or it's most likely pulmonary embolism, because if you look at your Wells criteria, you've got symptoms of DVT. That would be your left cap erythema and edema. There's 3 points right there. And then you've got the tachycardia, which is heart rate of 120. There's 1.5 points. And then more than likely, this is going to be pulmonary embolism because you don't have any other, you've got chest pain, you've got the shortness of breath. So there's really nothing else that this woman might have. It's certainly not an MI. She's too young. She doesn't have a fever, so it's not pneumonia. So this pulmonary embolism is most likely. So she's more than 4 points on the Wells criteria. So this is a pulmonary embolism until proven otherwise. Now, it doesn't show that she had a CT. She may have, but this is just a woman that's under your care. So if she has a pulmonary embolism, which we suspect that it is likely because that's what the Wells criteria tells us, if it's more than 4 points, what do we need to discontinue? Well, we need to discontinue the thing that may cause you to clot, and that is medroxyprogesterone. So women who are on birth control are at an increased risk for clotting. So different hypercoagulable states can be the inherited conditions like factor V Leiden, protein C or protein S deficiency, the prothrombin mutation. It can also include taking birth control pills, taking supplemental estrogen for postmenopausal, and it can include the state of being pregnant. So any of those things can put you in a hypercoagulable state, and this woman is taking medroxyprogesterone, and that is something that can put you at risk for DVT. The rest of them, citalopram is an antidepressant, alprazolam is a benzodiazepine, albuterol is a beta agonist for asthma, and acetaminophen is just Tylenol. None of those things put you at risk for clotting, just the medroxyprogesterone. Okay, a 31-year-old female presents to your clinic complaining of acne and a cough for the past several months. She has tried over-the-counter medications for both the cough and the acne, but nothing has worked at all. Her vitals are normal. On physical exam, you note red violation discoloration of her cheeks and tip of nose, as well as cervical lymphadenopathy. Based on the most likely diagnosis, which of the following is the best treatment for this patient? A. Clindamycin benzoyl peroxide topical, B. Albuterol, C. Prednisone, D. Sulfasalazine, or E. Dextromethorphan. And the answer here is C. Prednisone. So this woman has a red violation discoloration of her cheeks and tip of nose, which acne is usually not confined to a certain area, but okay, let's take that. She's also got cervical lymphadenopathy. Well, that's not consistent with acne at all. She's also got a cough, and it's been going on for a long time, and nothing has worked for it. More than likely, this woman has sarcoidosis. This red violaceous discoloration of the cheeks and, most importantly, the tip of nose is lupus pernio. Add that to the cervical lymphadenopathy, which lymphadenopathy is typical with sarcoidosis, and then the cough, you've got a clinical picture of sarcoidosis. Now, I'm not going to say you're going to give this woman prednisone without doing any kind of workup, but the question was, based on the most likely diagnosis, which of the following is the best treatment for this patient? So clindamycin benzoyl peroxide topical would be if she really had acne. That's a antibiotic that you can use for that. Albuterol would be if she had something that wasn't sarcoidosis, maybe like asthma or something. And then sulfasalazine is a disease-modifying agent, but you don't use it in sarcoidosis. Dextromethorphan is cough suppressant. That doesn't play a role in sarcoidosis at all. Prednisone is the cornerstone of therapy for sarcoidosis. So lupus pernio appears like this. Obviously, this is a much older patient that you can see this red violaceous discoloration. Here you see it particularly on the tip of the nose. So really need to remember that with sarcoidosis, you have this lupus pernio. And it's called lupus pernio because it's in your typical lupus, your distribution that you would normally have in lupus. Now it's not lupus, but it's on the upper cheeks and the nose, and that's where you would see your discoloration in a patient who's got lupus, regular lupus, SLE. So lupus pernio is a very typical presentation of sarcoidosis. Other things that you would see on chest X-ray, you would see hilar lymphadenopathy, which is just lymphadenopathy surrounding the heart and the base of the aorta. And another thing in this patient that points towards sarcoidosis is her lymphadenopathy, which is another thing that's commonly seen in sarcoidosis. Of course, in this woman, you're going to get a chest X-ray anyway because you want to look for hilar lymphadenopathy. That would pretty much solidify your diagnosis. Question 13. A 19-year-old college student presents to your clinic for an annual physical. He has a past medical history of asthma and major depressive disorder. His current medications include albuterol and escitalopram. He has no complaints and says, I only have to use my inhaler 1 or 2 times per day. Physical exam is unremarkable. Vitals are normal. Which of the following changes, if any, would you make to the management of this patient? A, continue current therapy. B, add theophylline. C, discontinue albuterol and add salmeterol and fluticasone inhaler. D, add salmeterol fluticasone inhaler, or E, oral corticosteroids. And the answer here is D, add salmeterol and fluticasone inhaler. So this is very typical. You have patients with asthma who don't really care how much and how often they're using their inhaler. They're using it maybe 5 times a week or every day or maybe even more than once a day. And they're just totally fine with that. That's not okay if you are managing a patient with asthma. That is not control of asthma if they're using their inhaler every day. So this is their short-acting beta-agonist inhaler, their rescue inhaler. If you're using that every day, you need more medication. And the first step we go to is going to be to a inhaled corticosteroid. So let's see here. Here. Okay. So the first step we would go to would be a low-dose inhaled corticosteroid. But the problem here is that this patient not only has mild asthma, he's got moderate asthma. He's using his inhaler every day. And so because he's in this moderate asthma, it's recommended that we go to step 3 rather than to step 2. So we're going to actually skip the next step. So the next step would be to go to, this isn't working, there we go. The next step would be to go to just adding a short-acting, giving a low-dose inhaled corticosteroid. But because he has the moderate asthma, we go to step 3. And step 3 is going to be to use a low-dose or medium-dose inhaled corticosteroid and a long-acting beta-agonist. So this is kind of a pain in the butt to remember, this severity chart, but you'll help yourself a lot if you do kind of remember the basics. Any patient who uses their inhaler every day, meaning they have daytime symptoms every day, all of those patients need to be on a long-term or a long-acting beta-agonist and corticosteroid. So this goes back to my hints that I give you. So all asthma patients get a short-acting beta-agonist. Okay, that's fine. That's what this guy has. If the patient is having daytime symptoms every day, then he needs a long-acting beta agonist. And if you're having symptoms more than once a week, then you need an inhaled corticosteroid. So yes, this patient is having symptoms more than twice a week, and he's actually having symptoms every day. So if you're having symptoms every day, then you need a beta agonist and an inhaled corticosteroid. So the long-acting beta agonist and the inhaled corticosteroid. The long-acting beta agonist plus inhaled corticosteroid is taken every day. It's not taken for rescue when you're having your acute symptoms. For that, you still use your albuterol. But you're going to take this every day, so it reduces your risk of needing that albuterol as frequently as every day. So sort of the steps we go is you diagnose the patient with asthma, you give them a beta agonist. If they have symptoms more than twice a week, then you give them an inhaled corticosteroid. If they're having symptoms every day, then you give them a long-acting beta agonist. Both the inhaled corticosteroid and the long-acting beta agonist are taken scheduled. They're taken every day. Unlike the beta agonist, the short-acting beta agonist, which is taken when you have symptoms. You're going to continue the short-acting beta agonist, though, for any patient with asthma. So we're just adding things on here. More than twice a week, add the inhaled corticosteroid. If you're having symptoms every day, then you add the long-acting beta agonist. And those would correspond to step 1, step 2, and step 3. And if the symptoms continue and get worse when you're at step 3, then you can increase the dose of the inhaled corticosteroid. So if the patient is at step 3, they're having symptoms every day, and yet you still can't get them controlled, they're still having symptoms every day or more than twice a week, then you just increase your dose of inhaled corticosteroid. So you go to a medium dose or then up to a high dose inhaled corticosteroid. If the patient continues to have symptoms after the high dose inhaled corticosteroid, at that point, then you can put them on an oral corticosteroid taper. As far as other drugs that you may use in patients with asthma, there is like montelukast or cromolyn. Those can be used as adjunctive therapy, particularly in children. They respond really well to those, but they're not used to replace corticosteroids or beta agonists or even oral steroids if necessary. They're just used as adjunctive therapy. If the patient has nighttime symptoms, if those are a major aspect of their asthma, nighttime symptoms, a good drug to use would be theophylline. So I would know this sort of step-up chart and know these 3 basic facts. All asthma patients get short-acting beta agonists like albuterol. If they've got symptoms more than twice a week, but not every day, then you can give them an inhaled corticosteroid alone. If they're having symptoms every day, then they need an inhaled corticosteroid plus beta agonist, long-acting beta agonist. And then from there, you just increase the dosage of the inhaled corticosteroid. Okay. Question 14. A 58-year-old woman under your care has been smoking and continues to smoke for the past 42 years. Previous workup includes chest x-ray and demonstrates hyperinflation and diaphragmatic flattening. Pulmonary function tests show an increased FEV1 to a decreased FEV1 to FVC ratio of 50%, not reversible with a bronchodilator. Which of the following is the most important component of the therapy for this patient? A. Home oxygen. B. Smoking cessation program. C. Salmeterol fluticasone inhaler. D. Regular exercise. Or E. Prophylactic antibiotics. All right, and the answer here is B. A smoking cessation program. So all of these things may be part of therapy in a patient with COPD, particularly A and C. Home oxygen, you're always going to give to a patient with COPD. Salmeterol fluticasone inhaler is good for helping the symptoms of a patient with COPD. But really, the oxygen and the inhaler are only good for the comfort of the patient. They're still required therapy for the COPD patient, particularly if they have severe COPD, but they only help the comfort. The smoking cessation can actually reduce the disease progression. You're still going to have COPD. You're still going to have it's still going to progress, but it can progress slower if you stop smoking. The smoking is just going to cause the disease to progress more rapidly. So you have to stop smoking if you want to reduce the progress of your COPD. But do remember that you cannot reverse COPD. It's non-reversible, but you can slow the progression. Regular exercise, of course, is always useful, but it's not going to reverse the COPD, and it's not going to slow down the progression if you're still smoking. Prophylactic antibiotics are used in a select group of COPD patients. Okay, question 15. A 21-year-old female presents to your clinic for routine physical. She has no complaints at this time. When taking the history, she says that she has a cough every day, which is productive, but this is typical for her as she has cystic fibrosis. Physical is unremarkable. Her last hospitalization was 5 years ago. You decide to order a chest x-ray to monitor her cystic fibrosis, and it shows bilateral tram tracking of the large bronchi. Which of the following would not be part of the current treatment plan for this patient? A, supplemental oxygen. B, incentive spirometry. C, chest physiotherapy. D, prophylactic antibiotics. Or E, Dornase alpha. Okay, answer here is A, supplemental home oxygen. So, patients with cystic fibrosis certainly need therapy. However, this patient seems to be pretty healthy. She does not have any symptoms of cyanosis or hypoxia, and she seems to be well controlled. She hasn't been in the hospital for 5 years. She just has, her only symptoms are a cough, a productive cough, which we would expect with cystic fibrosis. However, she does have bronchiectasis, and that is seen on the bilateral tram tracking of the large bronchi. Bronchiectasis is not common in the United States, but it is quite common in the patients who have cystic fibrosis, so that's generally where we see it. And bronchiectasis, all it is chronic inflammation of the larger airways, and because you have that chronic inflammation, it compensates the structure of the larger bronchi. So this is really an obstructive disease. It's an obstructive pulmonary disease, just like asthma and COPD, but it's in the larger bronchi. And what it is due to is it's due to chronic inflammation and infection, which happens in patients with cystic fibrosis. Why? Because patients with cystic fibrosis tend to have a thicker mucus, which is harder to expectorate, and they also have an impaired ciliary clearance system because the mutation with cystic fibrosis also affects their cilia. That's why male patients with cystic fibrosis are often non-fertile. So because they have both the thicker mucus and they have the impairment with their ciliary clearance system, it makes it more difficult for them to expectorate mucus out of their lungs, and it puts them at higher risk for infection. That chronic infection ultimately results in chronic inflammation. That chronic inflammation causes destruction of the elastin and the cartilage of the bronchi. So she has this bilateral tram tracking, which is consistent with bronchiectasis. So what do we need to do for her? Well, we need to make sure that she's, one, getting that mucus out, two, that she is, that we're treating her prophylactically for any kind of infection, particularly infection with Pseudomonas, and three, that we're helping make it easier for her to expectorate whatever mucus she's got down there. So incentive spirometry is always recommended in patients with cystic fibrosis. What does the incentive spirometry do? When you're doing that incentive spirometry, it's allowing you to take in deep breaths and then blow it out in a proper way so that you're getting air down to all the portions of your lungs. So that is good because when you're doing that incentive spirometry, it makes it easier for you to expectorate anything that's out in any part of your lungs. So incentive spirometry is always part of therapy in any patient with cystic fibrosis. Chest physiotherapy is an external device, usually that it pretty much pounds on the chest. And what that does is it loosens up any mucus that may be attached to the bronchi walls. So that's another thing that's very important because these patients have thicker mucus to help them get that mucus out. Prophylactic antibiotics are extremely important for patients with cystic fibrosis because we want to make sure that they do not develop Pseudomonas positive infections. So patients with cystic fibrosis often do have infections. That's what causes their inflammation that results in the bronchiectasis. But there's a particular bug that is really, really evil for patients with cystic fibrosis. And you want to avoid developing that kind of infection as much as possible. And that particular bug is Pseudomonas. So one of the antibiotics you would want them to be on prophylactically is an antibiotic that is effective against Pseudomonas. So something like tobramycin is commonly used in Pseudomonas infection. Piperacillin-tazobactam is another one. And then finally, Dornase alpha. What this is, it's a newer drug, and it essentially loosens up the mucus. I'm not exactly sure the mechanism, but what it is an expectorant. It makes the mucus thinner and makes it easier for cystic fibrosis patients to cough up whatever they've got down there. Supplemental home oxygen is not necessary for patients with cystic fibrosis if they are not showing any signs of hypoxia. If she starts to develop clubbing of the fingers and things like that, then supplemental oxygen may be useful. But it's not part of the current treatment plan at this time. The other four are more important. Okay, last question. A 21-year-old man presents to your clinic complaining of cough and fatigue, which he has noticed for the past couple months. He says he thinks it's allergies since he just moved to his grandparents' farm from the cities 3 months ago. Physical exam is only remarkable for fine crackles. You notice on the EMR, electronic medical record, that he has lost 15 pounds since his last checkup 4 months ago. He says he's not been trying to lose weight. Chest x-ray shows bilateral reticulonodular opacities in the middle and lower lung fields. Pulmonary function test shows overall reduced lung volumes. Which of the following would you recommend to this patient? A, albuterol inhaler, B, oral prednisone, C, Mantoux test, D, loratadine with budesonide inhaler, or E, minimize outdoor exposure at the farm. All right, and the answer here is E, minimize outdoor exposure at the farm. So this guy has hypersensitivity pneumonitis. How do we know that? Well, first off, he moved to a farm. Farms are full of different kinds of allergens that can cause hypersensitivity pneumonitis. There's a long list of things that can cause hypersensitivity pneumonitis, but some of the most common ones that you see are things that you would encounter on a farm. Bird poop, hay, different kinds of grass. So those all can cause hypersensitivity pneumonitis, and they're the most common we run into in the U.S. Another thing that's a dead giveaway is the weight loss. So this shows that he's got this subacute inflammation process, and that process is causing him to lose weight, and that's very, very, very common with hypersensitivity pneumonitis. If he didn't have that weight loss, we may think maybe it's allergies, and we might not get that chest x-ray. So that's very important, that weight loss. Of course, the chest x-ray is also a giveaway. With just general allergies, you don't get these bilateral reticulonodular opacities. So that's another thing that points towards hypersensitivity pneumonitis. And then furthermore, the pulmonary function test shows a restrictive pattern. Remember the mnemonic for restrictive lung diseases. That includes E, which is environmental. So remember, it's shit-faced. S for sarcoidosis, H for histiocytosis, I for interstitial pulmonary fibrosis, T for tuberculosis, F for fungal infections, A for alveolar proteinosis or asbestosis, C for collagen vascular disease, E for environmental, and D for drugs. So this would be the environmental. So this is a restrictive lung disease. So all of these put together show hypersensitivity pneumonitis. More specifically, farmer's lung. All right, so the only real therapy for patients who have hypersensitivity pneumonitis is going to be to minimize their exposure to whatever is causing that. And usually it's pretty obvious because it comes up in the patient's occupation or somewhere in their history. And particularly, this is a patient who didn't have any problems before. He moved to a farm and then he started developing these symptoms. So minimize outdoor exposure at the farm, see if the symptoms go away, if things improve. If they do, then you can diagnose him with hypersensitivity pneumonitis. If, for instance, in 6 months the symptoms do not remit, then you can do a further workup for diseases, particularly IPF. But more than likely, hypersensitivity pneumonitis is what this patient has. Albuterol inhaler does not work for patients with hypersensitivity pneumonitis because this is not a disease of the bronchi. This is a disease of the interstitium. Oral prednisone also does not work for hypersensitivity pneumonitis. However, it may be useful in reserved cases, but you're always going to have avoidance of exposure. Manto test would be appropriate if we were expecting or suspecting tuberculosis, but there's no reason to suspect that. It's rare in the US, plus we don't have any findings of tuberculosis on chest x-ray. And D, loratadine with budesonide inhaler. Frankly, I don't know whenever you use that. So loratadine is Claritin, used for allergies, but I don't know why you'd ever use that. I just put that in as a wrong answer. So minimize exposure whenever you have hypersensitivity pneumonitis. Hypersensitivity pneumonitis, you get sudden symptoms, you are exposed to occupational hazards, weight loss, and this abnormal chest x-ray restrictive pattern on pulmonary function tests. And that is it.